Hey, everybody, Dr. Ash back here with a little bit of information regarding blood transfusions. So, quick and dirty blood transfusions. What do I need to know? What's the most important role as a nurse when I'm dealing with blood transfusions? So, let's get started. So, first of all, don't get too crazy on this slide right here. This is just so you have an awareness that there are many types of blood products. A lot of people think just whole blood, like you go to donate blood, that's what's given to our patients, and that's not always the case. So what you commonly see that's red in a bag is packed red blood cells, and so that is the most common type that we give. It has to be compatible with whomever we are giving the packed red blood cells to. Typically we give a unit over about 2 to 4 hours, and generally what we do is we increase hemoglobin by 1 or hematocrit by 3% for every 1 unit we give. It's typically used for anemia, low hemoglobin, and hematocrit. Platelets, they don't necessarily need compatibility. The volume may vary depending on what's ordered, but typically this is used for thrombocytopenia, which is if your patient has low platelets. So makes sense. We also have something called fresh frozen plasma, which actually comes from the red blood cells and the platelets. It has to be compatible as well. And that's very good if you have a patient who is hemorrhaging out, because not only does it replace clotting factors in the body, but it also is a volume expander. We can also use cryoprecipitates as well. As the name implies, cryo, frozen. They are frozen for up to a year. And once they're thawed, they have to be given. They go bad. So typically cryo is ordered very sparingly because we don't want it to go to waste. And then there are some situations, although very rare, that we can infuse just granulocytes. And this is typically used in our septic patients or patients with very low white blood counts that are at high risk for infection. So then there's a couple of types of donations as well. Autologous donation that's when I donate my own blood. Like I'm going in for a procedure. The surgeon is worried that I might have a whole lot of blood loss, and so I actually donate blood to myself. And of course, your body does really good when it's your own blood. Something that's extremely uncommon is blood salvage, and that's basically where I have blood accumulated in body cavities. They suction that out, they wash it, they clean it, and then they give it as a infusion. And then there's something called a designated donor or a random donor. I would say random donor is probably your next most common, just because I'm in the hospital, I need blood, I get cross-matched, I get just a random donor that I don't know who it is. A lot of people feel more comfortable with a designated donor, but the problem is compatibility. So that may or may not be an option. So let's talk about blood compatibility. This is one of the important things that you probably need to know for NCLEX or a test, and that is the different donor types and who they can give it to. So type A can give to A or AB blood. B can be given to B or AB. AB only goes to AB. So AB to AB. And then blood O can be given to any blood type. And then, of course, we have something called an RH factor. And without getting too nerdy and chemistry on you, this is actually an antigen that sits on top of our blood cells, and it's either present, which is positive, or it's not, which is negative. And that's important because we do not want to give an RH negative person positive blood, because the negative person does not have that antigen. So if I give them positive blood, they're going to have a transfusion reaction. Okay. However, a positive person, so an O positive, can get either negative or positive blood. The universal donor is the O negative. That's because every single blood type, positive, negative, A, B, or O, can all receive O negative. The universal recipient is AB positive, meaning an AB can receive blood from anybody. So if you notice, an AB can get A, an AB can get B, an AB can get AB, and an AB can receive an O. Now we have this thing called type and cross match, and this is something that happens in the blood bank of whatever facility that you're working at. So basically typing means I have blood typed my patient. This is the vial of blood that I send downstairs. to the lab or wherever the lab is at, and it gets typed. So they give me an A, a B, or a positive or negative. And then the cross match means they take a sample of my blood, of whatever blood I sent down. I said mine, but your patient's blood, and they match it with the blood that they're going to potentially send you to transfuse. They do a little test on it, very small amounts, to see if it makes any sort of reaction in the blood. And so that's where we come up with the term type and cross match. All right, administration. Blood has to be given this way. It has to be given with an infusion pump. There is only one exception to that, and that is if your patient is in the ICU or the emergency room and they're hemorrhaging out and you're trying to pump it in faster than the pump will let it go. But for the most part, the general rule is you're going to be given it in an infusion pump. It must be with blood tubing that has a special filter on it to prevent clots from getting to your patient. We always check 2 patient identifiers using 2 registered nurses or 2 licensed nurses. We also are going to double check the order. We're going to make sure they have appropriate IV access. Blood requires informed consent. I don't even order blood from the blood bank until I know there's informed consent. And again, this is a situation non-emergent where we have time to talk to the patient. Okay, obviously, if there's a hemorrhage, there's an emergency situation. Sometimes we do what we feel is best for the patient, but if we can, we definitely need informed consent. Vital signs are a must. You guys have heard this 100 times. Vital signs provide a baseline. Same for a blood transfusion. I'm going to get a set of vital signs before I transfuse blood so I can quickly identify any changes, because we're going to talk about reactions here in just a few minutes. Always follow the agency policy. Every single agency that you go to will have a blood policy. Please make sure you know that, because that's what you will be held accountable to. You're going to stay with your patient for the first 15 minutes because that is kind of like the prime time. If a reaction is going to happen, it usually happens within the first 15 minutes. So complications of a transfusions are 2 big ones here. Transfusion reactions, which means my body has some sort of reaction to the transfusion, or fluid overload, because obviously we're given more volume back to the patient. And so we can have those signs of overload like crackles in the lungs, dyspnea, or difficulty breathing, tachypnea or fast breathing rate, changes in oxygen level, things of that nature. There is a small chance of septicemia, which we won't go into. Iron overload, if you go back into the anemia discussions, that is where our beta thalassemia major patients that get lots and lots of blood transfusions end up with iron overload. Of course, there's disease transmission, although it's much lower than it used to be because of all the testing that's done on blood products. It can cause hypocalcemia, hyperkalemia, and citrate toxicity. And those are just things to kind of keep in the back of your head. They don't happen very often, especially if you're only given like 1 or 2 units. The 2 big ones I want you to worry about are reactions and fluid overload. So transfusion reactions, this is an adverse, unexpected reaction to receiving some type of blood product. And there are a couple of types here. Again, I told you septicemia, which is outside of the talk here. There's a transfusion associated graft versus host disease. Again, way too advanced for what I want to go into. We have a febrile reaction, which means they have a fever greater than 100.5. So 101, 102, 103, you would stop. Okay. In any of these reactions, the very first thing you do is stop the infusion. Okay. Please remember that in the back of your head, always and forever. If you're concerned of a transfusion reaction, no matter what type it is, stop the infusion. There's a flat out allergic response. People can be just straight allergic to somebody else's blood. And then there can be a hemolytic reaction, which is much more severe because it actually starts to break down those red blood cells, or lytic breakdown. That's where that term comes from. So signs of a reaction, there's quite a few, but I have highlighted some for you that are most important. So fever, chills, shivering, diaphoresis, muscle aches, back pain, chest pain, that is primarily because of the immune response. Okay, that is an inflammatory response that is happening in response to non-compatible or incompatible blood. So we have to be very careful of fever, chills, shivering, diaphoresis, and back pain. Rash, hives, itching, and swelling, cough, difficulty breathing, wheezing. Those, of course, are allergic reaction types of signs. The patient may become very pale. They may have anxiety, a sense of impending doom, like, God, something's wrong, something bad is happening. They may even have some neurological symptoms, headache, nausea, vomiting, diarrhea, and cramping, but your big ones are highlighted at the top for you. So our priority actions, again, no matter what kind of reaction your patient is having, you are going to immediately stop that transfusion. You're going to disconnect the tubing all the way to the insertion site of the IV. Okay, so all the tubing has to be gone, because if you leave the tiniest little bit of blood in that IV, you're just exposing your patient to more of that blood that they are reacting to. So that IV tubing gets changed all the way to the IV site. We then will hang brand new tubing and start to infuse normal saline. One of the other things that you want to do is you want to double check the patient and the blood ID. Blood products always come up with a barcode. They come up with the patient identification, all of that good stuff. And so that has to be double checked to make sure there wasn't an error at the bedside. We have to notify the provider and the blood bank. We're going to stay with the patient, of course, vital signs, because that's what we do. They may need some sort of emergency drug like epinephrine or Benadryl, depending on if they're having an allergic reaction. We end up returning everything back to the blood bank so they can investigate like why this happened, right? Because we talked about cross type and cross match. We should have caught it before it ever was going to be a problem. Just saying. And then there's usually a host of blood work that goes along anytime your patient has a transfusion reaction. And that's it, guys. So, like, wow, that was really fast. But again, it's everything you need to know about blood transfusions, quick, down and dirty, which is how I like it. So make sure you like, subscribe, and share, and I will see you next time.